Pulmonary angiography. It has been traditionally considered the gold standard for diagnosis of pulmonary embolism because it was the only imaging technique that directly visualized the filling defects caused by thrombi and or emboli. It is expensive, invasive, and requires a highly trained angiographer. It is reliable for centrally located thrombi. However, there is a high inter-observer disagreement for subsegmental emboli. The IVC filter can be placed following the study. Pulmonary angiography has a sensitivity of 90% at least and a specificity of 95% plus. The morbidity is less than 3% and the mortality is less than 0.5%. The primary and the pathognomonic signs of pulmonary thromboembolism are the presence of filling defects in the pulmonary arteries and the abrupt obstruction of pulmonary arteries. Secondary signs may even be more common, but are non-specific. They consist of focal flow retardation, delayed filling and emptying of the affected vessels, the marked tapering of the arteries, tortuosity of the arteries, and peripheral hypovascularity. Peripheral hypovascularity can be seen in some patients with pulmonary emphysema, patient with pulmonary veno-occlusive disease, and therefore it is not a pathognomonic sign, although the majority of emboli are lodged in peripheral vessels that are the size of an arteriole, which is 0.1 millimeter in diameter, 100 micra. So those small vessels are generally not visible radiographically and are the most commonly involved sites for pulmonary emboli. So flow retardation, delayed emptying of the pulmonary arteries, asymmetric pulmonary blood flow probably are more common than filling defects seen in the pulmonary circulation. This is a patient with a massive pulmonary embolism. Note the complete obstruction of the left pulmonary artery. The left lung was not perfused at all. And note the filling defects in right upper lobe, pulmonary artery. Another patient with multiple filling defects in proximal pulmonary arteries. Note in this selective left pulmonary angiogram the abrupt interruption of arteries due to emboli in branches that supply the periphery of the left base. In this patient, we have evidence of central and peripheral pulmonary arterial occlusions. The central pulmonary artery to most of the right lower lobe accounts for the hyperlucency that we note in the right base. Note that we can see veins from the right upper lobe and persistent arterial visualization in a segmental artery to the right middle lobe and in an anterior basilar artery to the right lower lobe. This means that a shower of emboli occluded these latter segments, and that explains the simultaneous arterial and venous opacification. Flow retardation in the middle lobe and some portion of the right lower lobe was related to the occlusion of prearterioles in those. A poor angiographic examination is worse than no angiographic study. In this patient, a frontal angiogram was interpreted as a negative. But note that we have not injected in this patient adequate amounts of contrast material. So the total volume of contrast and the delivery rate are standardized and must be used always to visualize the pulmonary arteries. And when the thromboembolic process cannot be recognized on a frontal projection, we should use selective right and left pulmonary injections and use more than one projection. Selective right pulmonary arteriogram in the same patient rotated into the left posterior oblique projection shows filling defects in right lower pulmonary artery. So the study was positive, not negative as initially suspected. A later phase shows asymmetric blood flow to the right. A later phase of the same examination shows filling defects in right lower pulmonary arteries and a hypoperfusion of subsegmental branches of the right lower lobe pulmonary. This is a selected right pulmonary arteriogram in a patient with chronic pulmonary thromboembolism. Note the markedly enlarged central pulmonary arteries. Note the abrupt termination of many intra-arterial branches and sudden changes in the caliber of some intrapulmonary arteries. Tortuosity of the arteries to the right lower lobe are another sign of the chronicity of pulmonary arterial hypertension. However, we do not see the pathognomonic sign, which is the filling defect. A suggestion that this is thromboembolic is to see the abrupt transition of caliber between centrally enlarged arteries and arteries to segments and subsegments of the lung that are markedly. Another patient with chronic pulmonary thromboembolism, and note that the central arteries are markedly enlarged. There is tortuosity of intrapulmonary arteries and peripheral oligemia. We do not see the presence of filling defects, which are the pathognomonic sign. However, we see the abrupt termination and changes in the caliber of the pulmonary arteries that suggest the chronicity of pulmonary thromboembolism. This is a CT to your left and an angiogram to your right of a patient with chronic pulmonary thromboembolism. The CT study shows ground glass mosaic pattern due to hypoperfusion of some areas and relatively increased perfusion of uninvolved segments. Note in the angiogram the massively enlarged proximal pulmonary arteries and the peripheral oligodendrocytes.